Okay, so so how I became involved in the erosive toothware was actually, so my very first meeting as president-elect for BSDHT, so nearly 2 years ago, I was invited to attend a working group, and that was co-chaired with David Bartlett and Soha Donati from GSK. And I went to Guy's. So I trained as a dental hygienist at Guy's. I think most of you do know I was a dental nurse as well first. And I trained at Leeds with Janet Goodwin as a dental nurse. She was my tutor. And so anyway, so I went to Guy's to train as a hygienist. My very first meeting as president-elect was at Guy's Hospital. And it was a little bit overwhelming actually, but anyway, but really, really good day. So so David Bartlett was chairing, and I was sat in a room with a lot of very well-known and very well-respected members of our profession, including Nen Wilson, Ian Mills, Nigel Potts, and it was just a little bit overwhelming, but it was a brilliant day. They made me feel very welcome, and I've learned a lot about erosive toothware and BEWE since, and so I'm still, the group is still working. We don't meet that regularly, but we're still getting stuff out there. So so it is an ongoing thing, and I'm still part of this working group that goes on. And the idea of it and the focus of it was that David Bartlett, he had put together what they call the BEWE tool about in the early 2000s, and it was there to, and I'll talk about it a lot more in a short while, but it was there to form like a screening tool for erosive toothware. And it hadn't really, the uptake of it within practices, within the teaching hospitals, hadn't been as great as he thought it would have been. And it'd been used in lots of other countries over the world, across the world, but really not as much in the UK. And the reason for this working group was to really try and promote erosive toothware and the BEWE back into dental schools, training all the team, so for hygiene and therapy, for BDS students, but also getting it out there into practice, and making it part, a bit like BPE. BPE, everyone knows about BPE, and that's what he wants for BEWE as well. And the two go very well together, actually. They do go very, very well together. And so that was the main focus of the group, and that's what we've been working on. For those of you who have come across GSK reps recently, they've been talking a lot about erosive toothware as well. The one thing you will notice about this is that it's non-branded, so it is supported by GSK, but it's a non-branded thing. And just for transparency as well, I'm not being sponsored by GSK today, so this is me speaking as a dental hygienist to you in the knowledge and the things that I've learned and known as a result of being part of this working group. So that's where we are at the moment. I will also just say that, yes, that the working group was supported by GlaxoSmithKline, but everything, all the information, all the educational material is research, it's evidence-based. David Bartlett, Saoirse O'Toole, who's on the other one, Saoirse O'Toole, who's on there as well. They work very closely together at King's and on a lot of the research as well. Saoirse is also working in our practice as well, which is fabulous. So that's where we're up to. So basically the aim for today is to provide dental nurses with some knowledge of erosive toothware, how they can be involved in discussions with the patient for the prevention of further tooth surface loss, and your role as well in implementing the BEWE into a dental practice. And then I've put the objectives there for you as well. Okay. I'm just going to try and just see if I can just make this a bit smaller, because it's a little bit distracting. Okay, so what is erosive toothware? So what is erosive toothware? Well, erosive toothware really it's the combination of erosion and physical wear. So when we have acid on our teeth, anything that's acidic, or we get an acid environment within our mouth, The erosive tooth wear is the acid that then combines with the erosion that causes the erosion and physical wear as well. And that can be, as this shows, it can be abrasion, so toothbrush abrasion, any kind of abrasion, and also attrition as well, so clenching, grinding. I think going back to work in post the first lockdown and in this pandemic, we are seeing so much attrition. We're seeing a lot of, not so much abrasion cavities, but definitely a lot of attrition, a lot of tooth wear, a lot of clenching, grinding, cheek biting, all those kind of things. And so this is where it is quite important, because if you're getting patients that are not only clenching and grinding because they're so stressed and they're, anxious about everything, and they're also having quite a high acid kind of diet, and then brushing their teeth on top of that every time they've eaten something that's got a lot of acid, like with lots of acid, then this is going to create a lot more tooth wear and a lot more erosive tooth wear as well. So the difference between so how they work, well, we'll go over how they work in a second, but the difference between caries and erosive tooth wear is basically caries is bacterial, and the acid is formed as a result of the bacteria and the plaque reacting with the food, with the sugars, and that's what's causing the acid. So caries is much more of a bacterial base, where erosive tooth wear is much more of a physical, it's much more extrinsic, it's much more physical, and you often find that that you get a lot of tooth wear in patients that actually brush their teeth really, really well. And so usually you find tooth wear on clean teeth and plaque-free surfaces. So on the occlusal surface, you're definitely going to find much more wear. The key teeth to always look for are the upper anteriors, as you can see on this photograph. There's lots of wear there, and there's some palatal erosion as well, and also on the molars as well. Now, from your point of view as nurses, it could be just even looking when you're talking to a patient, you're in a conversation with the patient, and you just notice. So you may notice more anterior wear. And we'll go through the different kinds of things, the clinical signs that you need to look for, but having a look at those as you're talking to a patient may be able to just start some kind of conversations rolling. So some of the statistics that I wanted just to get to you, to point out to you, which I think are quite pertinent and I think are actually very relevant and is important that you know, is that tooth wear is actually a very, very common issue. It's a very common condition, and it affects about 30% of adults in the UK currently. And it's actually we've got so most people think of dental diseases as being caries and periodontitis, periodontal disease. And so erosive tooth wear is actually the third factor, is the third one. And so it's the third dental disease, and that's what they're phrasing it as. It's the third one. So not only we're now looking at caries and we're not looking just at caries and perio, we're also looking at erosive tooth wear. It's also, I will talk to you, and it's also quite impacts on children as well, and it's good to be aware with the children. It is a preventable condition, and it generally is looking at diet and reflux, and so those are the two major issues with regards to erosive tooth wear, and this is what we'll talk about today. So the prevalence of erosive tooth wear. So basically, we are oh, sorry, I'm just going to admit Bethany. There you go, Bethany. As a population, we're an aging population, and so people are generally keeping their teeth much longer. So not only we're living longer, but with the advances in care, dental care, although probably wouldn't believe in the situation we've been in this year that dental care is actually helping people to continue to keep their teeth longer. People generally are. So if people are living to their 80s and 90s, and keeping their teeth, then we're going to see much more incidence of erosive tooth wear. I had actually earlier this year, I had 3 patients back to back who were all in their 90s, which I thought was quite interesting, and they were all dentate patients as well. In fact, actually, none of them had dentures or anything. One had a partial denture, and the others were completely completely dentate, quite completely. So one had a partial, that was all. So yeah, so I had 4, and there were 3 ladies, all in their 90s, which I think was pretty impressive, and they were back to back as well. Children, if you see erosive tooth wear in children, it is a risk factor for adulthood, and so it's worth always being aware with the children as well. You'll notice with children, when you see them, maybe their deciduous teeth, they're very worn, they're very short, and you can tell, and you can see that when you're talking to them as well. So be aware of that, because if we can, like we do with caries as well with children, if we can deal with that when they're small children and younger, then we can help them as they get older. I've worked in the practice I work in, I've worked there for 24 years. So I have seen children grow up pretty much there. And I have one patient springs to mind who he's seen me pretty much most of his life, really, since he had teeth. And he's now 18. And until he had a full permanent dentition, caries, he had baby teeth, he had deciduous teeth extracted. And so not always for ortho reasons, mainly for caries, but because we've worked with him so well, his permanent dentition, he has no issues, everything's sealed, and he does really, really well now, and he's actually brushing his teeth very well as well, which is good. So be aware of those kind of things, particularly with children as well, and picking up on that. Erosive tooth wear is a global issue. However, the impact, probably the UK has the highest rates of erosive tooth wear. Now it could be related to our diet. It could be related to the fact that maybe there's more screening going on in the UK, and that's why it's higher. Or it could be more that there is more screening, but we also need to get the message across a lot better, because maybe we're not doing that in quite the way we should be. So the rates in the UK are quite high in comparison to other countries where BEWE is out there and being utilised. So the clinical signs, let's see if this will work. So looking at the screen on the right, you'll see there's very little, in fact, very little wear on these upper anteriors. So these are the anteriors. This is what you can be looking for when you're talking to patients, welcoming patients, talking to patients while you're maybe waiting for the dentist or the hygienist or the therapist to be in the room with you. You could be just doing some triaging, that kind of thing. So have a look while you're talking. Notice these things as well. So so looking at the anteriors, there's minimal wear on the left side, the first one on the left. The middle photograph, you can see there's some moderate wear around the around the gingival 2/3 of the tooth, and then on the photograph on the right, you'll see there is much more severe tooth wear. We've got pretty much the distal of the upper right tooth that's pretty much gone. There's a nice big sort of curve on the upper left one as well. So that's more severe. Sometimes you see shortening of teeth, so the crowns are much shorter, very stubby like, that kind of thing. Looking out for those kind of things, okay? On the posterior teeth, again, on the left-hand side, that photograph, very minimal tooth surface loss. The middle one, more moderate. You see this kind of pitting, these little kind of pits in the teeth, and that's a real classic sign. And we want to try and make sure that that definitely doesn't get to this kind of stage, which is on the right, which is very advanced erosive tooth wear. These patients, incredible sensitivity, because it's basically enamel. In fact, actually on this one, you can see the enamel, and you can also see the dentine as well. So these patients are going to probably have a lot of sensitivity as well. And it's not a particularly pleasant thing at all. So how do we get to this phase? How do we get to this stage? So the etiology of erosive tooth wear is really with the tooth. We have the tooth when we have anything acidic. So much in the same way as caries, anything acidic, so acidic drinks, acidic fruit, foods, things like that, reflux, having any kind of acid in the mouth. We're going to lose, when we have those acid challenges, we lose the calcium and the phosphate salts from the enamel. And so when a patient then either brushes or is clenching or grinding. So if you've got a patient that is having, they're having, so during lockdown, there was a huge increase in people having glasses of wine of an evening, or a beer or something like that. Actually, beer's not too bad, but a glass of wine, something that's quite acidic. And then so they have a glass of wine in the evening, and then they brush their teeth before they go to bed. That's going to be, so you've already got the softened enamel, you've got brushing, then they go to bed, they're very anxious, they're a bit stressed, so they're clenching and grinding their teeth. That's going to cause attrition and the erosion. And so, but hopefully what we're trying to do then is just to help to sorry, there you go, Sarah. So then what we're trying to do then, if we can get some fluoride back into the tooth, or some calcium salt, if we can get the calcium and the fluoride in, then it builds a nice resistance to any further erosive tooth wear. So it's all about the acid challenges, remineralization, demineralization, and remineralization, and that's what we're working towards. So the risk factors. So basically acidic diets, so lots of like tropical fruits, melons, lemons, grapefruit, things like that, all those kind of diets. So quite an acidic kind of diet. The frequency, so how often and we're going to talk about this in just a short while. So the frequency of when we're eating and drinking, again, like we do with caries, you don't want too much in between meals. And then how we're eating our food, how we're drinking our drinks as well. And again, we'll talk about that in a short while. And then also eating habits. We used to treat a family that were originally from Germany. They were a German family. And in Germany, it seems that there's a lot more grazing. They do a lot more grazing rather than sitting down for a whole meal every every evening. They sort of graze throughout the day. And this particular family, the mum used to make lots of, and it sounded delicious actually, but really nice, like lots of food, and she'd have it out on the table, and the children would be snacking and grazing throughout the whole day. And actually, she had two older girls and then a younger son, and the son he had quite a lot of caries issues as well. So being aware of how people are eating, are they snacking a lot, are they grazing, those kind of things, and it's being a bit more aware of that as well. So what we look for is we want foods and drinks that have a low erosive value, medium and high. Now, and this is related to the pH. It's not always about the pH, but it's actually the amount of acid that you get, and the sort of the degree of acid within the food and the drinks. So something like carbonated water actually has quite a low pH, and so actually that's really not that bad. And a beer isn't too bad either. Where when you've got a glass of wine, higher pH, and so or orange juice. The worst one, which is the one I love the most, is apple juice. I love apple juice. Very high erosive. It has a very high erosive potential, and also obviously grapefruit juice as well. And Coke's just not very good for you at all, really, because it's got a lot of sugar as well as being quite acidic. But so things like, we're looking more with regards to like sparkling water, still water, those kind of things. So where that's more related to the diet as a risk factor. The other consideration is reflux, and it is something to be aware of. Now, this is one of my patients, and I've treated this lady for probably about 22 years, I think. And you'll see that she has some palatal wear. You'll see that she's got four beautiful anterior crowns, which my boss Linda did. But you'll also see it on the canines, and then palatally on the premolars, and you can just see you can see the premolars. There is palatal wear, and the reason why she has those beautiful crowns is because she actually had quite extensive palatal wear. Now, we've worked with her for many, many years, and always aware of this, and we were trying to work out what was causing it, because she has a very, very good diet. She kind of eats to live rather than lives to eat. And so, but her diet is is a good diet, a very healthy diet. She doesn't really snack. She doesn't really she doesn't do any of the typical things that we would look at. But one thing that she did find out eventually, and she was only actually diagnosed in her, I think she was in her mid-40s, so probably about 10 years ago, that she had some kind of syndrome that caused reflux, and she'd basically been having reflux for pretty much most of her life and wasn't really that aware of it. And so anyway, so she's on medication now, and she has some medication for it. She's very much aware of it, and she manages it very, very well. And we manage it well in that we're screening constantly, we take photographs, and we just keep monitoring this as we go along. It's not got worse, it's pretty stable now. She's happy, so all's good. But it's good to just be aware of these things. Okay. So recording the erosive tooth wear. So this is where it's really important that we have this tool available to us that we can record. It is a screening tool, but it is there and something that we can use and utilize to be able to record this. One of the things and one of the main reasons as well that David Bartlett and his team at King's, they wanted to get this out there more, is because there probably is more likely to be more claims now of undiagnosed tooth wear and erosive tooth wear as well, and the patient's not being informed of this, it's not being monitored, those kind of things. And so it could be something that's kind of after perio, it's the next thing that patients start picking up on, is that I wasn't told I had tooth wear, I wasn't told it was erosive, I wasn't told it could be prevented, those kind of things. So this is why we need this tool. So it's called the Basic Erosive Tooth Wear Examination, and that's where the BEWE acronym comes in. It's a very simple tool, and the idea is that it's utilised alongside the BPE. So it's not anything that needs to be onerous. It is a screening tool. It doesn't need to be, it doesn't need to take a long time. It can be done it can be done quite quickly, very, very quickly. It's designed as a screening tool to alert the practitioner, but also the patient as well. And this is where you can come in on this as well. And we'll talk about that in just a short while. It's quick and it is efficient, and it is something that obviously I am implementing into practice now. As the name indicates, it's the role. It's there to grade the tooth, and it's not purely about erosion. It's there to grade the amount of tooth surface loss. And it doesn't have to necessarily indicate any erosive restorative intervention. So like BPA gives you get the score, and then it gives you a guide on what kind of treatment you should be providing. It gives you a guide then for that as well, for the treatment. So when we're performing a BEWE, we look at, it's again like the BPE, it's done into sextants. So we have the upper right, upper left sextant, and upper anteriors, and then the same on the lower. So it's done in 6 sextants, exactly like you would with BPE. And what I'm going to do is I'm going to just pause, and I'm going to let you listen to Saoirse and David, because I hope you can hear this. If you can't, just put a note up.
Examination, or BEWE, is a simple tool to be used by healthcare professionals to record and screen for erosive tooth wear in practice. It was originally developed in 2008 by researchers, clinicians, and academics to help record tooth wear. And since then, it has been widely adopted as the tool to record erosive tooth wear in general practice.
To measure the BEWE, go through each sextant, measuring the surface with the greatest amount of wear. You then come to a cumulative score, giving you an indication of how much erosive tooth wear is present. 0 is no wear, 1 is early damage to the teeth, 2 is less than 50%, 3 is greater than 50%. So we're going to do a BEWE score in the lower jaw, the lower right sextant, the anterior teeth, the lower left sextant. Look at each tooth, and the tooth with the greatest amount of wear is in that sextant is given the BEWE score. So in this case, there's a filling on that tooth The premolars are unworn, probably a grade 1. The lower anterior teeth, very little wear at all, grade 1, and the lower left on the occlusal surface, there's dentine exposed over the whole surface. The wear is greater than 50%, grade 3. In the upper jaw, there's a fair amount of occlusal wear on all of these teeth. Upper left sextant, probably a grade 3. Premolars, the anterior teeth are restored, not much wear, probably a grade 1. On the upper right side, little evidence, and the BEWE, quite a lot of occlusal wear, but no dentine exposed, grade 2.
So that's how we would grade it. I'll go through that in just 1 second. Oh, there we go. So as David and Saoirse just explained, so if we have, if there's no loss, or very, very minimal, it's a 0. And then, and you're looking at, so we'll look at the tooth surface. If there's very early signs, and that's usually the hardest bit, it's actually finding those, like noticing those very, very early signs of wear. And that's a BEWE 1. And then if it's less than 50% of the tooth surface, it's a 3. Sorry, it's a 2. And if it's more than 50%, it's a grade 3. And so exactly like we do with BPE, we do it in exactly the same way. So the little grid can look exactly the same. So we have upper right, upper anteriors, upper left. So upper right 2, upper right is 1, upper left is 3, lower left is 2, lower anteriors is 1, and then lower right is grade 3. And so that's how we would score it. Okay. Now, as David mentioned, you get a cumulative score that then will direct you in how we should, the advice that we would be giving to the patients. So this one gave us a cumulative score of 12. Now I will go back to what we do with that cumulative score. We'll go through that in just a little while. So with children, it is again actually one of our BSDH members actually just emailed me this week actually, and I was actually in the middle. It was a bit spooky really, because I was actually in the middle of just making some changes to my presentation, as I always am. I'm always making changes to them because you can always make them a bit better. And so I was just making a few changes, and this email pinged up, and she said, "It's probably not right, but do you do BEWE on children?" And I said, "Yes, you do." Oh, and she didn't know that. So anyway, so I'd informed her that yes, you do it on children. And it is a good idea, as we talked about earlier, that it is a risk factor for adulthood and permanent dentition. So yes, so we would do exactly the same on children as well. So exactly the same, and grade the tooth wear in exactly the same way. Okay. And you will find that we're always going to get a faster rate with the child because we've got much less enamel, a lot more dentine. So it can be used for the children, and it's actually advocated that we do use it on children. And it basically, again, we would just work with exactly the same format as we do for adults as well. Okay, but it is important that we do that, and then make sure that we inform the patient and the patient and their carers that we are going to do this screening tool as well. So your roles and responsibilities as dental nurses within this, how can you be involved in this? What's in it? How can you help to implement this? Well, there's lots of different ways. So first of all, I think I was thinking of things, how you can be involved. And actually, I didn't actually get a chance to do it, but I was just thinking earlier about triaging as well. So if you're doing remote triage, which I've been doing remote triage for my patients as well, going back to work. But if you're doing remote triage for patients and asking some of the questions with regards to sensitivity, clenching, grinding, if you have finding out a little bit about any changes in their diet, if they've had any sensitivity, that could be an indication. Could also be dentine sensitivity, but it could be an indication. if they are clenching and grinding quite a lot, TMJ issues, those kind of things. So those can all have an impact. And then in combination with their diet, if you're checking alcohol consumption, diet, those kind of things over that time, health, medication, those kind of things, then that could give you an indication that there could be some erosive tooth wear and to be looking out for that. So, so you can also do it in remote triage. You could also be aware of that with when you're doing your remote triaging before you see before the patients come in. Informing patients during when they have an oral health assessment. So, you know, if you're explaining to the patient that the clinician today is going to be doing, you know, a BPE exam, we're going to evaluate the health of your gums, we're going to evaluate the health of your teeth, we're going to check for any dental decay, and we're also going to check for so any tooth wear, any tooth surface loss or erosive tooth surface loss. You can use either term, it really doesn't matter. But you can explain that to them and explain these are the things we're going to be looking for. We're doing an oral, as Annette was just talking about, she was talking more about skin lesions, but we could be looking oral cancer screenings. It's all part of what we do. So when you're, you know, a new patient coming into the practice, you can, and you go through the things that you're looking for and that we're going to be doing in our initial assessment or with existing patients, you can add that to the list of things that we're doing now. And it gives that much more comprehensive evaluation. You can explain how the BEWE works. So much in the same ways we explain how a BPE works or 6-point pocket chart if you're doing with perio. You can explain exactly how that works. It's a screening tool, and we're going to call out some numbers and we choose the most severe in each part of your mouth, and we're going to record that. So obviously assisting while we're doing the recording and of the actual BEWE, so noting that as well. And it may be that you have to prompt the clinician, the dentist you're working with, the therapist.
The big tree. You want it there, or can I put it down the back of it? No.
Whatever you think will be safe.
No, it's not safe. It's where it looks best.
Hmm.
No.
Could you just, sorry, could you just possibly put your
I'll be happy with whatever you
speakers, excuse me, could you just possibly put all your mics onto mute, please, while Diane's talking?
Oh, 1 second. Sorry, Fiona, this is where I go all a bit.
No, it's okay. We just get the audience to put all of their mics on
okay.
On mute, and then we won't hear background noise. Sorry, Diane.
It's all right. I think it's Sheila. I can see it. Do you want me to just sit? Oh, okay. So recording, and then, you know, my favourite one, which is always photographs. It's important, and I go on about this all the time. I'm always, you know, photographs is my thing, as well as whitening. But anyway, so it is important. It's important to record. It's really important to record these. And sometimes, as I mentioned earlier, we don't always have, like, you don't always spot those early signs of erosive tooth wear. And so by having records and tracking patients, it's really, really important that we do that, because we can then identify any deterioration, not only with everything that we're doing. So I'm a big fan of photographs, and I also think it's good for you to be able to see those as well, and just to track those as well. I like taking photographs because I like putting them on my presentations as well. My poor patients. So actually, when the first time I did this presentation, I think I had a morning where I had like 6 patients, I had 3 patients one morning, and they all had different parts, the bit of erosive tooth wear. And I was like, can I just take some photographs? Because I've got a presentation to do next week, that kind of thing. So they do get subjected to quite a lot, my patients. Yeah, so photographs, use the skill, get the skill and use it, because you can be so useful, and it can be so. All the nurses in our practice all take photographs. That's one of the things they're all trained on. Strategies for prevention. So it is important. I'm just checking what time. Oh, we're doing all right for time. So it is important that we make sure that we're informing the patient, and we're also educating them. If you're going to inform them about something, we need to give them the tools to be able to either prevent or to manage the situation that they're in. And again, this is where you can all come in, really help. You know, it's part of what we're doing, that whole teamwork, working as a team, and this is something to be very much worked on. So if you remember going back to how we did the BEWE, so it gave us a score of 12, which is moderate, okay, moderate wear, medium sort of wear. Now this is the guidance, this is sort of the parameters that David and his team put together, and it is based on the values are based, as it says at the bottom, are based on their experience. So what they were seeing. So obviously they've been treating patients and studying and doing the research for many years now. And so this is how, and they were sort of finding that anything between like up to 6, like 0 to 6, were okay, you know, quite low. We could handle that with just diet, just checking their diet, oral hygiene. Not always oral hygiene though, because generally, as we said before, it's generally quite clean teeth and plaque-free teeth that end up with more erosive wear. And just making sure that we continue to see those patients and monitor those patients. And then the more medium ones, again, assessing their diet, routine fluoride, so either fluoride varnish, you know, fluoride jet, like fluoride varnish, toothpastes, those kind of things. You want to try and make sure that you avoid those big restorations, that we're not doing these big restorations, and then keep making sure that you reevaluate and redo the screening on a regular basis, at least every 3 to 6 months. So when they're either in hygiene or doing their oral health assessment with their dentist, either of those would be good to do that. And it's just getting into that habit of doing it. It's just getting into that habit of doing it the whole time. And then the high risk patients, the high ones, are those when we're in the 13 and above, and they need the advice. They need to be coached. They need supervision. They need to be back there with you and having that sort of follow up and help and encouragement. And they probably are looking at restorations as well, which a lot of people, which is again becoming much more apparent as well. So some of these, so if you find you've got a patient and they're in that kind of that medium category, the high risk category, we need to start asking. I mean, you can actually ask the questions as earlier on as well, when they're sort of even in the low ones, just so we're getting it out there. We're just making them aware of these things that are going on in their mouths. And it's not just always about decay and about gum disease. So first question is basically, you know, how many dietary acids are you consuming daily? So how much fruit, anything with lots of like fruit flavorings, acidic drinks, acidic sweets. The medications is actually, are they taking medications? Are they taking medication? And finding out what that medication is, because if it's something like omeprazole or Lanzaprol, then the chances are they have reflux, and they might not divulge that, or they might just, mostly they would, but looking at what medications they're taking can give you an indication of what that could be, and it could be something relating to reflux. So have a look at, so ask them how many like acidy drinks, fruits are you consuming each day? Do you have anything between meals? Sounding very much caries based, but are you having anything between meals? Are you eating anything between meals? Do you spend more than 10 minutes consuming any dietary acid at a single sitting? So are you sitting there eating, you know, sat at my desk eating melon in the summer, melon, you know, and you sit eating melon, watermelons and things like that, or oranges. I'd quite think about oranges. And actually I did a challenge for one of our colleagues, Tim Ives. I did a challenge for him in the summer, which I've continued, and it was 28 days of no added sugar. So I wasn't eating much in the way of like biscuits and cake and things like that, and I was eating much more fruit. So again, it's being aware when you're eating that fruit, what you're eating. So oranges, melons, strawberries, you know, those kind of things. So is that, do you sit eating them while you're working at your desk, or do you just go eat them and then have a break and don't keep picking, those kind of things? Okay. And then lastly, how do you eat? How do you eat? How do you drink? And it sounds a bit strange that how do you eat and drink, but do you sip? Do you swish water? Do you swish and like a can of Coke around your mouth, a glass of wine, you know, if you have a glass of wine, swish it around, you know, those kind of things. Do you do that before, or hold it in your mouth before you swallow? Do that, because that is actually, again, releasing the acid into the mouth. So looking at those kind of things, asking those questions and getting the answers to those. So the key message that the patients need to know is that erosive tooth wear is preventable. And with some changes, some small changes, it doesn't need to be big changes, just small changes to how they eat, how they drink, how they consume the food, when they consume the food and the drinks can make such a massive difference, such a big difference. And the key thing is frequency. So if you're having more than 3 dietary acid attacks each day, then the chances of tooth wear increases 13 times, like by 13. If we have 1 per day, nothing. There's no risk. And eating and drinking with anything that's very acidic with meals is no risk at all as well. So really, it's actually like it is with caries. It's trying to stop those frequent snacking, eating between meals, keeping everything to meal times, those kind of things. It's all sounding very familiar. So you can work on this in relation to caries as well. So when should we be eating these things? So fruit and tooth wear. If you have it with meals every day, so we all know that fruit's generally pretty good for us. And so if we're eating fruit, try and again eat it with meals. Don't keep snacking, don't keep like grazing, those kind of things. Once a day between meals can just double our chances, and twice a day between meals is 5 times the chance that you're going to get erosive tooth wear, more wear. And then with drinks, that's much more, there's much more of a consequence there. So once a day is double. Will double the chances if you have it with meals. If you have an acidic drink, so a glass of wine or a Coke, if you have it once a day between meals, 2.5 times the chance that you're going to have some kind of erosive tooth wear. And if you have it with meals, if you have the same drink with a meal twice a day, then you're more likely to have 6 times. And if you have it twice a day between meals, 11 times greater. So it's quite significant. So what you want to be doing really is encouraging the patients to be going more either once or no snacking, or nothing that's really acidic between meals at all, and just keeping anything acidic to meal times. And that's probably the best. So advice to our patients, this is what can be advising the patients. And again, this is where your role can come in very easily. We're all good. Dental nurses, dental hygienists, dental therapists are all very good at talking to patients, offering advice, and communicating really well. There's lots of dentists that are very good at communicating as well, but we traditionally seem to be in that role. So eating lots of fruit, making sure we're eating our fruit, but make sure we have it with meal times. So if you're having lots of particularly tropical fruits, that kind of thing, definitely having more at meal times. Don't sip or swish. Try and drink through a straw is much better. And I purposely chose paper straws as well for sustainability, and try not to graze too much as well. Watch out for combinations of acids. So if you have orange juice for breakfast, so everyone loves like the freshly squeezed orange, juicing, that kind of thing, loads of acid, lots of acid, really high acid content. So keep that. If you're having it at breakfast, then try not to start having fizzy drinks at lunchtime. You want to be looking more at water or milk, probably sparkling water or something like that at lunchtime. So if it was just one, if you had to choose one, the other one as well that's quite popular is lemon and hot water in the morning, because apparently that cleanses out your system and makes you feel better for the day. And I also had a patient that he was doing, and I haven't had much of it recently, but there was another trend as well, was apple cider vinegar. And that was, again, and apple cider vinegar isn't far off battery acid, it's pretty high up there. So it has a lot of, I think there's lots of good things about it, but you have to be really careful from oral health point of view and erosive tooth wear point of view with apple cider vinegar. So I think there's some, I haven't really looked into what the health benefits are, but there is apparently health benefits in and it's possibly diluted as well. But be aware of that as well, because there's lots of different trends that go on. And yeah, I had this patient who had been reading and thought it was a good way to go. And so I think it made the calculus a little bit green, if I'm honest. I was trying to take some nice photographs of that one day. Follow a healthy diet and make sure you do your 5-a-day. Always aim for that 5-a-day, be advocating 5-a-day and making sure that we're getting that healthy diet message across as well to the patients. And then again, just trying to make sure that if they're going to have anything that's really acidic, so eat it quickly, drink it quickly. Anything, if you don't want a patient to be, well, we all know we don't want patients sipping on Coca-Cola, apple juice, don't sip on it for like 20 minutes, half an hour. Make sure you just drink it quickly. I always like I do love apple juice because I'm not a great fan of orange juice, but I always have it with lots of ice, and I love it in the summer with lots of ice. So I just fill a glass with ice and then pour the apple juice just on top. So as the ice melts, it's actually diluting the apple juice as well. So which obviously lowers the pH and the acid content as well. And then try not to have too many fizzy drinks or fruit juices every day. Try to encourage the patients not to have fizzy drinks every day or fruit juices every day, and just have it as maybe like with everything else, a treat, a weekend thing, something like that. Or have them with meal times, okay? Have them, a freshly squeezed orange is probably a lot better for you than a Fanta or lemonade or something like that. It's much better for you, okay? So those are just some of the straightforward things just to think about, things that we can offer our patients, we can advise our patients on. So what's good? So the good things we're looking for are plain and sparkling water, milk, tea and coffee in the way of drinks. Be aware of sugar-free drinks, because they still have quite a high erosive content, and be aware of that. So anything that's sugar-free is generally replaced with some kind of sweetener. So be aware of that as well, because there's still potential for high acid content. And make sure again as well that you just look for any hidden dietary acids. Everything's hidden sugars, and anything that's really acid. So things like pickles, lemons, putting lemon in water, which I've just said about, cordials, those kind of things. Okay, just be aware of those. So on a more of a preventative basis for our patients, we want to make sure we can help them to again prevent. Okay, so not only with the diet, but also with diet and habits, changing those habits, getting them into different habits, keeping everything to meal times, the key things. We can also obviously advise them to make sure that they keep brushing with a good fluoridated toothpaste. And we're looking at somewhere at least 1,450 parts per million, and they're brushing twice a day. You just wait. Obviously, we're going to let them know that the fluoride is always going to protect the enamel. And also choose toothpaste that are a lot less abrasive. So you always want a lower RDA value on your toothpaste as well. And then make sure that you advise the patient not to brush straight after eating or drinking anything acidic, and make sure that they leave it for at least 20 minutes, half an hour. So there's always been, there's always the question, do you advise a patient to brush before or after their breakfast? And so again, be aware of that, because that's one question that I get asked a lot, like, shall I brush before or after breakfast? And it probably is, there's merit in brushing before, and then there's merit in brushing afterwards, but leaving it for at least 20 minutes, half an hour, just so we get that remineralization going before we start brushing. And then we're not going to have that acid attack and that abrasion. And then just make sure that we don't, the more abrasive toothpaste, so things like, oh, actually, I'm going to get it in there, whitening toothpaste, generally seem to be a bit more abrasive, charcoal toothpaste, those kind of things. Anything that's really, really abrasive, you don't want those kind of toothpastes, because they're going to initiate greater wear as well. So top tips to minimize the risk. We're almost there now, I think. Make sure that we want to make sure that we minimize the risk. We want to make sure that patients know about this as early as we possibly can, like we do with caries, like we do with perio. So we've got to get that message out to the patients as early as we can. So making sure that we continue to always do that erosive tooth wear examination and make it part of your oral health assessment so that you don't miss that diagnosis. So always make sure that it is part of it, build it into the examination in the practice, make sure that it gets carried out on a routine basis. And again, it's just, keeping a good habit, getting into good habits with it. Routine, making sure that we're recording in using the BEWE and giving that, documenting it so we can give that preventative advice. And then inform the patient of the extent of the current condition and the areas that you're going to monitor, that need to be monitored. So those are the things. So if they, feel a little bit alarmed by it, we can, just explain to them, this is what we found today. We're going to keep watching this. These are things you can do at home. These are things you can help to prevent it getting any worse. And we will keep, on our part, we will keep monitoring. Oh, doesn't want to do that. Sorry, there we go. And then just make sure the patients understand the importance of looking after their own oral health and managing their own risk factors. It's all of the patients have to take on that responsibility. When I trained as a hygienist, it was all about us having the responsibility. And it's such a hard thing sometimes to shift to putting the onus on the patient. And that's where we're at now. Patients have to be responsible for their own health, for their own well-being, and we have to provide them with the tools and the information and the education so they can make those informed decisions, so that then they can help, they can ensure that they're looking after their own, not just oral health, but general health. So having those tools in place, having that information in place, and making sure we keep doing the screening tools. So these are just some of this is the Erosive Tooth Wear Foundation. This is Nigel Pitts. Nigel Pitts is involved with the Erosive Tooth Wear Foundation. It is a charity, and they have loads of information on their website. So I've put the website at the bottom, and there's lots of information. There's also a downloadable thing that you can have if you have, I think it works for R4, definitely works for Exact. For Software of Excellence, the Exact program, and it can actually, so it's a downloadable kind of patch that then you can have the BEWE screening tool, so you can document it on there. Me personally, I tried to download it and it didn't quite work. I'm not sure why. I think it's something to do with our computers at work. So what I do is actually I go into BPE and I do my BPE, because I do them in conjunction, so I do them together, and I chart BPE on one and then the BEWE on the other, and then I make a note in the notes box and put BEWE score, and obviously it's dated. So I have two. So I generally have two, and I generally do it like that, and it actually works quite well because you can see both. So and then I'll make a note, and then I obviously reflect that in my written notes as well, that I've carried out the BEWE on that day. So it is something that hopefully, a lot of the newer graduates, the BDS students are being taught it much more, and there's much more of awareness getting out there. We've had David present at our conference last year, and it's just getting out there just a lot more now. So hopefully it is something that you will start to see in practice. It's maybe something that you can go back into practice on Monday and say, hey, we were learning about this, and do you think it's something we should be looking at? Give them the tools and make people aware. I work with my boss, Linda. Her son is also a dentist. He graduated in 2018, and one of his fellow students who qualified with him in the same year also works in our practice for a couple of days a week now, because he's doing his master's. And interestingly, Joseph, Linda's son, he does BEWE pretty routinely as part of his oral health assessment, and his friend Benny doesn't generally do it as often, and sometimes I have to kind of nudge him and say, hey, tooth wear, and he's like, oh yeah. So again, it's just getting into habits, and sometimes you have to just nudge people to just remind them of that. So with that, I will say thank you, and if anyone's got any questions, I'm happy to answer any questions. I'll just go like that, and then I can see Fiona's back.
Yeah. Claire, do you want to come in and just have a look for any questions?
Sorry, I was 2 minutes over. Sorry.
No, actually, well, we've run into everybody's time because of my technical glitch this morning. So please don't apologise. And we're all engrossed with this. I'm just going to get Claire to do these questions and then encourage everybody to stay for the award ceremony, because we've actually got some additional awards for delegates as well. So over to you, Claire.
Oh, brilliant. That was brilliant. Thank you, Diane. I did put a question in, actually. Well, not so much a question, but kind of just echoing the importance of it, really. But I'll come to that one afterwards as to why I think it's so important we do it. So our first question. So the public are aware of decay and its relation to sugar, but I only found out about acid erosion and the food and the drinks it was linked to when studying for my hygiene module. Many also falling into foods that are generally considered healthy, like fruit.
Yeah.
Do you think the public would benefit from being made aware of acid erosion to the same extent that they are made aware of dental decay? And do you think this could be delivered by dental nurses in the community targeting younger age groups?
Yes, definitely. And it's something that most definitely. It's something that I think it can be, definitely. I think going into schools when we're allowed to, or however we're going to do it, you know, those kind of things, going into the schools, making them aware. There is such a focus, and this was the whole point of this working group, was put together because they really felt, you know, the incidence was going up. The chances are, we had Raj Rattan is part of that group as well. So he's indemnity, and one of the reasons why they've been looking at this is because there is a concern that, you know, it's going to end up being undiagnosed perio and undiagnosed erosive tooth wear, because patients are potentially, I wouldn't say maybe losing teeth because of it, but I think there is Saoirse did a study on roughly, and they worked it out, it's roughly somewhere between, if you had something that was quite serious erosion, you know, something like those grade 3s where I showed you on the molars, where there was, you know, lots of exposed dentine, you know, the enamel was very translucent, that kind of thing. You know, you're looking at average something where around about £10,000 to £15,000 to restore. Wow. And it's restorations. If they come to our practice, it's probably double that. But Linda is excellent, so I'm not going to say anything. No, she's brilliant. And she's done some restorative. I mean, she's learned from she's done a lot of work on that kind of work anyway. But it's very it's very, you know, it's not cheap. It's not just doing a filling. It's not just doing one single inlay. It's quadrants at a time. So and that's where there is that fear that it's going to end up being, not only is it going to be, you know, undiagnosed perio, it's going to be undiagnosed erosive tooth wear as well. So yeah, definitely. And getting it into the schools early. I was with a friend the other day and her daughter, and we're out for 2 hours. There was a swizzle lolly, an ice cream, and a carton of apple juice. And I'm just like, oh, the whole time. So, yeah, I do have conversations with some of my friends and their children about this situation. And my last year was with some friends who were over from Australia, and their son Mark, healthiest boy you've ever. He's very healthy, but blimey, does that boy consume a lot of Coca-Cola? And I actually had a word with him about it and his mother. I'm terrible.
What is your opinion then on the carbonated fizzy water? I know you did mention it.
It's actually quite low. It's not real. The pH on carbonated water is actually very, very low, is quite low. So it's really not an issue. Carbonated water isn't too bad. I always thought that it was as you shouldn't be doing carbonated water, but actually it's really, it's the tritatable acid content is actually not that high, and so from that point of view it's really not too bad. So carbonated water is okay. What you don't want is you know, the ones that they then stick the fruit flavors in,
the soda stream.
Yeah, and that, you know, like the kind of you know, the Volvic ones where they've got like the water and then they stick it. Well, and that's probably because there's sugar in the flavor, the fruit, that kind of thing. So you just don't want that. no. So I generally, and probably because for those, Fiona knows, I've always got a bottle of water with me, and it's always still water, just tap water, because I just drink water. I don't drink tea and coffee. And occasionally I have a glass of wine. Everyone needs a glass of wine sometimes, but I've still got my little bottle here. This is my bottle of cava from Thursday nights following our AGM. So from Julie. So, and that was all I've had. So I'm not that bad, but yeah, you've got to be very, just really careful. But I would just say stick with plain water and a bit of carbonated water, really.
Okay, brilliant.
If water was meant to have fruits in it, fruit flavour in it, it would come out the sky or out the stream with it in, so it doesn't.
Well, I guess, yeah, you've got a very, very valid point there.
You've got
next
one more, Claire.
Yeah, is a brilliant question. How effective is enamel regeneration treatment in an effort to reverse early tooth wear?
Okay, so it can help. I mean, obviously we want to prevent. We always want to prevent rather than have to regenerate. So we want to work on the prevention. There are obviously products out there, and we all know that there's Pro Enamel. There's also lots of other ones, and I'll just say it now in this arena. There's things like tooth mousse, MI paste, those kind of things that all can help. Okay, because they're not sponsoring me, so it's fine. But they all help. As long as you're getting calcium and phosphate back into the tooth, that's what you want. Okay, so things like Pro Enamel are good. Things like tooth mousse, MI paste, those kind of things, fabulous. Go with it. And actually what they do as well is they create, because they're a bit more there's a flavour to them, they actually stimulate more saliva. So you're getting not only the calcium and the phosphate from the product, but also saliva as well.